folks. It's great to be getting back to some nerdy educational goodness, so thanks for tuning in for Talk Nerdy to Me 5.0. This is the first one of these I've been able to do for quite a while thanks to our dear friend COVID-19. It's been an interesting couple of years to say the least, and I hope all of you are safe and healthy and all doing well. Before we actually go ahead and get into the talk, it's time for me to do my annual disclosure. I am genuinely sorry to say that I still do not have any financial conflicts of interest to report, although I am open to offers. In this talk, we're going to discuss a few really great publications that address two topics that are very pertinent to the care of patients in the emergency department. First, we'll talk about what's new relating to therapeutic hypothermia. Do we chill or not to chill? Second, we'll look at endovascular therapy of whether we should give thrombolytics prior to endovascular therapy, or whether to, quote, drip and ship. This has been of great interest to emergency physicians as this continues to evolve. We're going to look at a meta-analysis of several papers addressing this question, to lyse or not to lyse. We won't discuss in this talk is any of the thousands upon thousands of papers that have been published specifically on COVID-19. There are numerous other publications and presentations that go into this in much greater detail than I could possibly do in this talk. So I thought it was more important to highlight some other topics that maybe haven't gotten the attention they deserve. So I thought it would be an appropriate goal to highlight a couple of non-COVID updates that might otherwise have passed by unnoticed. You probably all remember that I am a big fan of giving you a mental break every so often during one of my presentations. So for this month, I thought it would be fun to look at the concept of correlation versus causation. I'm sure you're all aware that correlation does not necessarily equate to causation. So I thought it might be nice to illustrate this concept with a few entertaining graphs, and I will let you be the judge regarding correlation versus causation. All right, let's get into our first topic. For nearly 2 decades, we have been aggressively cooling patients after out-of-hospital cardiac arrest, in the hopes of improving the likelihood of a favorable neurologic outcome. This was based primarily on the HACA trial, published in 2002, that demonstrated a 14% survival benefit in patients cooled to 33 degrees after out-of-hospital cardiac arrest. Unfortunately, there were a ton of problems with this trial, including being non-blinded, that only patients with ventricular fibrillation and ventricular tachycardia were included, and most notably, that many patients in the control group were allowed to develop hyperthermia. Nonetheless, this paper started us down the path of aggressively cooling comatose survivors of out-of-hospital cardiac arrest. A number of other trials since then have been published, some supporting the findings of the original paper, while others have challenged this practice, most notably the targeted temperature management trial in 2013, which demonstrated no difference in outcomes when patients were maintained at 36 versus 33 degrees. This paper suggests that it's actually avoidance of hyperthermia that is probably more important than actually achieving hypothermia. However, this has left clinicians in a place of uncertainty, as there was also some discordance among the guidelines on what we should do for these patients. Last year, the TTM2 investigators performed the largest and the most definitive trial to date examining the efficacy of therapeutic hypothermia versus normothermia. This is an international, multi-center, randomized controlled trial of comatose patients presenting with out-of-hospital cardiac arrest. Patients had to have maintained return of spontaneous circulation for at least 20 minutes before being enrolled, which makes sense because we don't want to enroll a bunch of people who don't survive long enough to undergo the intervention. But patients were also excluded if more than 180 minutes had passed, again, to ensure that the intervention happened in a timely fashion. Patients were also excluded if it was an unwitnessed cardiac arrest with asystole as the presenting rhythm, as the likelihood of survival in this group is basically zero to begin with. I'm super happy that they decided to include patients regardless of presenting rhythm. Many of the previous trials only included patients with either VF or VT as their presenting rhythm, but despite this, hypothermia has been broadly recommended for all comatose post-arrest patients. So this is a much more accurate representation of what we actually do in clinical practice. Of course, the question we have to ask now is, why does any of this matter? Well, I think that we all genuinely want the best possible neurologic outcome for our patients. So if hypothermia works to achieve this outcome for our patients, then it's worth putting the effort into achieving it. But hypothermia is also not a benign intervention. It comes with a host of its own metabolic disruptions, and when studied for other indications, such as traumatic brain injury, it has become clear that inducing hypothermia can also produce harm. First of all, hypothermia is known to produce dysrhythmias. Hypothermia can produce or worsen hemodynamic instability. Hypothermia also increases the risk of infection. And hypothermia has been demonstrated to prolong the duration of mechanical ventilation and CNS depression. And of course, hypothermia is very resource intensive and, frankly, is just a pain in the ass. In this trial, a total of 1,861 patients were randomized. I should point out that this trial includes more patients than all of the previous trials combined, which certainly lends a degree of credibility to the results. Patients in the intervention group were actively cooled with either a surface or vascular device to a core temperature of 33 degrees for 28 hours, and then gradually returned to a temperature of 36.5 to 37.5 degrees. The normothermia group did not undergo any active temperature intervention unless their temperature exceeded 37.8 degrees, at which time the patients were cooled to and maintained at a temperature of 37.5 degrees. Sedation was mandatory and was standardized in both groups, and both groups were returned to normothermia for 72 hours prior to evaluation of neurologic status. So patients in both groups underwent neuroprognostication no earlier than 96 hours after randomization. The primary outcome was death from any cause at 6 months. The main secondary outcomes included functional outcome at 6 months as assessed with the modified Rankin scale. And just as a quick reminder, a Rankin score of 0 to 2 is generally considered a pretty good outcome, as with a Rankin score of 2, you can still live independently. They also looked at a bunch of pre-planned subgroups, as well as a number of adverse events, such as the development of pneumonia, sepsis, major bleeding, dysrhythmia resulting in hemodynamic instability, and complications related to the temperature management device. Blinding is always a challenge in a trial like this. As you might imagine, the people who were providing the actual bedside patient care could not feasibly be blinded to the treatment groups because of the interventions and monitoring that are necessary to maintain hypothermia. But the physicians who were performing the neurofunctional evaluation and doing the neurologic prognostication were blinded, as were the administrators of the trial, the statisticians, and the authors. In fact, the authors went so far as to have written a manuscript for publication for both possibilities based on the data before they even found out which group was which. Between the groups, they did a pretty good job of ensuring that the hypothermia group actually got cold, and that the normothermia group stayed normothermic. There were a few people that had to be deprotocolized because of complications. They couldn't maintain hemodynamic stability once cooled all the way to 33, and so on. But overall, the intervention was very well maintained. All right, I don't know about you, but I think it's time to take a quick mental break. So, I looked at this graph and I thought that bees and spiders sort of have something in common, but again, I'll leave the decision of correlation versus causation up to you. Overall, the outcomes were not statistically different between any of the groups for either the primary outcome or for any of the secondary outcomes. Most notably, this trial failed to demonstrate any mortality benefit, which is different than the early trials on therapeutic hypothermia, but is consistent with findings of the more recent and more methodologically sound TTM1 trial. The one exception to this was that when we examined adverse events, there was a statistically significant increase in the number of symptomatic dysrhythmias in the hypothermia group, which suggests that there is at least some degree of harm associated with therapeutic hypothermia. When we look more closely at the breakdown of functional outcomes between the groups, the overall distribution of functional status at 6 months was virtually identical. The reason this matters is because even if overall mortality was the same, if hypothermia produced more rank in 1s and 2s as opposed to 2s and 3s, that in and of itself may have value, but unfortunately this was not the case. It appears that hypothermia did not really add any benefit to functional outcomes over maintenance of normothermia. One of the most common questions many people tend to ask is, why did the early trials suggest a benefit when the more recent trials don't seem to demonstrate the same benefit? There are a number of reasons why this might occur. Overall, the later trials just had better methodology. Most of the early trials were not subject to a substantial degree of bias. The initial trials were also quite a bit smaller than the later trials, and in the early trials, a ton of patients were screened but not enrolled, suggesting that there could also have been substantial selection bias and some degree of survivor bias occurring. Subsequent studies have included many more patients who would have been excluded from the initial trials, which is good because this provides us with a more realistic assessment of how this will play out in our actual practice. So the bottom line for hypothermia is that induction of therapeutic hypothermia does not appear to improve survival after out-of-hospital cardiac arrest. There is some concern that there may be harm due to increased frequency of dysrhythmias with therapeutic hypothermia, and currently, maintenance of normothermia is what's recommended for your survivors of out-of-hospital cardiac arrest. All right, I think we're about ready for another mental break, so let's take a minute here and take another look at some correlations versus causations. I got nothing on causation here. Let's move on and talk about a few important things that have happened in the management of acute stroke. In the last decade, the big change that has happened to our care of stroke patients is the development of effective endovascular retrieval therapy. Our goal is to rapidly identify patients that have large vessel occlusions, these patients to a center capable of performing a neurovascular procedure to extract the occlusion and restore blood flow to the brain. There are multiple large trials, including the Mr. Clean, Extend IA, Swift Prime, Escape, and Revascat, that demonstrated that this approach is more effective than standard thrombolysis for large vessel occlusions. And so, this has essentially become the new standard of care in the management of acute strokes with large vessel occlusion. The question that we now need to ask is whether we should still be giving patients with large vessel occlusions intravenous thrombolytics prior to sending them for endovascular therapy. If you recall, something similar was tried for myocardial infarctions patients going to the cath lab. This was referred to as facilitated PCI. It was thought that giving lytics and then taking the patient for emergent revascularization might improve outcomes. But they actually demonstrated the opposite when this approach was studied, which is why it was subsequently abandoned. So the question remains, will lysing patients before going for endovascular therapy improve outcomes, harm, or does it make any difference at all? There are some interesting arguments on both sides of this debate, but until recently we didn't have any real data to guide us. Fortunately, in the last 2 years, a number of studies have been published to address this question, including the DIRECT-MT, MR Clean No IV, the DEVT trial, and the SKIP trial. Fortunately, the folks at the BMJ published a meta-analysis of the findings of these 4 trials in 2021. By combining the 4 trials, there were a total of 1,633 patients, with 817, or 50% of the participants, randomly assigned to endovascular therapy alone, and 816 randomized to IV thrombolysis prior to endovascular therapy. The average NIH score of the patients included in these studies was between 16 and 19, so these were some pretty sick folks that had profound deficits. 2 of the trials were conducted in China, 1 was in Japan, and the last was conducted in Europe, primarily in the Netherlands, France, and Belgium. All enrolled patients that had a large vessel occlusion in the anterior circulation and presented directly to a major thrombectomy-capable hospital. So it's worth noting that these trials did not include any patients who got transferred in. These 4 studies were included after an extensive literature search that identified a total of 1,525 studies for evaluation and assessment. The majority were excluded because they did not meet the inclusion criteria for the meta-analysis, which included, number 1, that the study design was an RCT, 2, that the patient had a diagnosis of anterior circulation large vessel occlusion, number 3, that the trials compared endovascular therapy alone versus IV thrombolysis prior to endovascular therapy, and last, that the trials reported an endpoint of functional independence defined as a modified Rankin scale at 90 days. Now, as we all know, a meta-analysis is only as good as the quality of the studies that went into it. As the saying goes, if you put garbage in, you're still going to get garbage out. So before we look at the meta-analysis overall, I feel like we need to take just a couple of minutes and briefly talk about the 4 trials that went into it. The DIRECT-MT trial was performed in China and enrolled patients over 18 years of age presenting within 4.5 hours of stroke symptom onset and who had findings of a large vessel occlusion on CT and CT angiography. The primary outcome was the proportion of patients achieving functional dependence, defined by the modified Rankin score at 90 days by a blinded assessor. There were a number of secondary outcomes, the most important including an assessment of disability at 90 days, the rate of symptomatic intracranial hemorrhage, successful reperfusion, and death at 90 days, as well as procedural complications. There was no statistically significant difference in the primary outcome, which was the distribution of modified Rankin scores at 30 days. There were also no significant differences in any of the secondary outcomes, including the rates of procedural complication, death at 90 days, or symptomatic intracranial hemorrhage. A few key take-homes regarding this trial as compared to the others. In this trial, the median NIH scores was 17, so these were pretty sick folks. The patients and clinicians were not blinded, but the neurologists performing assessment of functional status were blinded. There was no placebo used in the endovascular alone group. And lastly, this trial was done in China, which raises some questions about generalizability to other healthcare systems. The DEVT trial enrolled patients greater than 18 years of age presenting within 4.5 hours of stroke symptom onset and who had findings of a large vessel occlusion on CT-CTA or on MR-MRA imaging, and who also had a favorable ischemic penumbra, so this trial actually included perfusion imaging as well. In this trial, the primary outcome was the proportion of patients achieving functional independence, defined as a modified Rankin score of 0 to 2 assessed at 90 days by a blinded assessor. There were a number of secondary outcomes, the most important including an assessment of disability at 90 days, the rate of symptomatic intracranial hemorrhage, successful reperfusion, and death at 90 days, as well as procedural complications. Regarding the primary outcome, this trial clearly demonstrated non-inferiority of endovascular therapy alone versus endovascular therapy plus IV thrombolysis. As for the secondary outcomes, there were no significant differences in the rate of symptomatic intracranial hemorrhage or 90-day mortality. There was a close to significant trend towards an increased rate of procedural complications in the TPA group. The key take-homes regarding this trial as compared to the others were that in this trial, the median NIH score was 16, so again, pretty sick. The patients and clinicians were not blinded, but the neurologist performing assessment of functional status were blinded. Again, no placebo was used in the endovascular alone group, and this trial was also done in China, which again raises questions about generalizability to other healthcare systems. However, this trial was done at multiple institutions, which does increase the likelihood of generalizability. This trial also had a very impressive retention of subjects, as they did not lose any patients to follow-up. The SKIP trial enrolled patients over 18 and under 85, presenting within 4.5 hours of stroke symptom onset, and who had findings of a large vessel occlusion on CT-CTA or MR-MRA imaging. And also, they did perfusion imaging as well, and the patients needed to have a favorable ischemic penumbra. The primary outcome was the proportion of patients achieving functional independence defined as a modified Rankin score of 0 to 2 assessed at 90 days by a blinded assessor. There were a number of secondary outcomes, the most important including an assessment of disability at 90 days, the rate of symptomatic intracranial hemorrhage, successful reperfusion, and death at 90 days, as well as procedural complications. Overall, no statistically significant differences were found in the primary or secondary outcomes in this trial, and endovascular therapy alone was demonstrated to be statistically non-inferior. The main differences in this trial as compared to the others were that in this trial a slightly lower DPA was given, 0.6 milligrams per kilogram, as opposed to the more standard 0.9 milligram per kilogram dosing regimen. The patients and clinicians were not blinded, but the neurologists performing assessment of functional status were blinded. There was no placebo used in the endovascular alone group, and despite randomization, the endovascular therapy alone group had a median NIH score of 19 versus 17 in the TPA plus endovascular group. However, if anything, that should have skewed the data in favor of the TPA group, and yet the study still demonstrated non-inferiority. This trial was performed in Japan, which again raises some questions about generalizability to other healthcare systems, but also included patients from multiple Japanese institutions, which does bolster generalizability. Finally, we have the Mr. Clean No IV trial, which was published in November 2021. Their findings had been presented at a major conference prior to its formal publication, and that's how it ended up in the meta-analysis that was e-published before the trial itself actually was published. Mr. Clean No patients over the age of 18, presenting within 4.5 hours of stroke symptom onset, and who had findings of a large vessel occlusion either on CT-CTA or on MR-MRA imaging, but perfusion imaging was not required. The primary outcome was a comparison of the distribution of functional status at 90 days as assessed by a blinded assessor. There were a number of secondary outcomes, the most important including an assessment of disability at 90 days, rate of symptomatic intracranial hemorrhage, successful reperfusion, and death at 90 days, as well as procedural complications. Unlike the prior 3 trials, this trial did not demonstrate non-inferiority of endovascular therapy alone over endovascular therapy plus TPA based on their pre-specified thresholds. However, the findings also did not demonstrate any clinically or statistically significant differences between any of the studied outcomes, so technically they also didn't demonstrate inferiority either. The main differences in this trial as compared to the others included that in this trial, randomization wasn't ideal, and the endovascular therapy alone group ended up being just a little bit sicker than the endovascular therapy plus TPA group, as the endovascular therapy alone group had more atrial fibrillation, they were slightly older, and overall had more prognostically unfavorable clots based on size and location. The patients and the clinicians were again not blinded, but the neurologists performing the assessment of functionals were blinded. There was no placebo used in the endovascular alone group, and this trial was performed in multiple European nations. Its multinational recruitment base is a bit more favorable regarding generalizability, but it still excludes a number of populations. All right, that was pretty dense stuff. I think it's time to take another little mental break. All right, now that we've taken just a few minutes to touch on a few of the trials included, let's get back to the meta-analysis and dig into it. The primary outcome was functional independence, defined as a modified Rankin score of 0 to 2 at 90 days, and secondary outcomes included freedom from disability as a modified Rankin of score of 0 to 1 at 90 days, successful reperfusion, symptomatic intracranial hemorrhage, and all-cause mortality at 90 days. Overall, the patients were surprisingly well matched across all of the studies. NIH scores were overall pretty similar as well, but for whatever reason there were fewer patients in the DEVT trial with an internal carotid artery occlusion as opposed to the other studies. And as noted above, there were also a few places throughout the trials where randomization failed to produce an exact balance. In all of these trials, the time from randomization to arterial puncture was also impressively fast. The patients included also had similar rates of things like hypertension, diabetes, prior stroke, and a history of atherosclerotic disease. Approximately 50% of the patients in the meta-analysis had atrial fibrillation. While there is, of course, always some heterogeneity when we combine studies, the overall similarity of the patients included across these 4 papers means that we can pretty comfortably combine the data from the 4 studies for analysis. When the data from all 4 of the included trials was analyzed, there were no statistically significant differences between any of the outcomes studied. Thrombolysis does not appear to offer any advantage over endovascular therapy alone, as the data demonstrated that endovascular therapy alone appears to be non-inferior regarding functional independence at 90 days. Regarding the secondary outcomes, there was a trend towards an increase in overall intracranial hemorrhage in the thrombolytic group, which is precisely what one would expect. But it did not appear to result in any significant increases in symptomatic intracranial hemorrhage or worsening functional status. All right, buckle up, friends, because now we have to talk about the dreaded confidence interval. A confidence interval is the probability that a parameter will fall between a pair of values around the mean. The majority of research will use a 95% confidence interval, and this paper is no exception. So, say you had 100 patients. In this meta-analysis, the lower limit of the 95% confidence interval for achieving functional independence at 90 days was -4. That means that at worst, with endovascular therapy alone, 4 fewer patients would achieve functional independence than with the combination of endovascular therapy plus TPA. On the flip side, the upper limit of the 95% confidence interval was 5. This means that at best, with endovascular therapy alone, 5 more patients may achieve functional independence than the combination of endovascular therapy plus TPA. This meta-analysis employed a non-inferiority design. This type of study tries to determine whether a new treatment is not worse than an active treatment it is being compared to. As such, the authors have to decide at what threshold is a treatment non-inferior. If it's within 2% is good, 5% is good, maybe 10% is good. The inferiority threshold is typically specified in the methods prior to initiation of data collection. In this study, The authors actually examined multiple thresholds, including 15%, 10%, 6.5%, 5%, and 1.3%. Since the lower limit of the confidence interval is -4, that means that the endovascular therapy alone met all but the most stringent of the non-inferiority thresholds pre-specified in this analysis. The authors state that the reason they used a multi-level analysis was to allow clinicians to decide for themselves what threshold of non-inferiority they are willing to accept. This paper was able to demonstrate within a 5% threshold that endovascular therapy alone is non-inferior to TPA plus endovascular therapy. I think that that's a completely reasonable threshold for non-inferiority, considering that none of the trials or the meta-analysis demonstrated a clinically significant difference in any of the primary or secondary outcomes that matter. Frankly, I suspect that in order to demonstrate a difference with a threshold as small as 1.3%, I think you're going to need a bigger trial. Now, let's go through our checklist and grade the quality of the meta-analysis. Did they do a good search and select pertinent studies? Yes, they did a thorough literature search and selected the papers most relevant to the question being asked. Next, were the patients included similar enough to be combined for meta-analysis? I won't torture you by reading the entire table one to you, but as we discussed a few slides ago, this one also gets a yes. There was actually surprisingly little heterogeneity for meta-analysis, and overall, the cohorts were similar enough to be analyzed as a group. The outcomes measured and their methods were also quite similar across the 4 trials. Next, were the statistical methods well described? This one also gets a yes. They described in detail in the paper how the articles were selected, how and by whom the data was abstracted, and how they analyzed the data that was abstracted. Next, is the overall risk of bias low, uncertain, or high? This paper used the Cochrane Risk for Bias Tool 2.0 for evaluation of the papers, and the bias was found to be low overall for all 4. And of course, anytime you're evaluating a trial or a study, it's always a good idea to look and see who paid for the study and which authors may have conflicts of interest. This meta-analysis itself was funded by a scientific grant and was not funded by industry dollars. One of the authors, Dr. Saver, is well known for significant ties to the pharmaceutical industry, and this was disclosed in the paper. And next, are the conclusions stated by the authors supported by the data in the paper? And this one also gets a yes. The statistical data in the paper does support the conclusions as described by the author. And lastly, did the authors include a frank discussion regarding the limitations of their data, including what conclusions can reasonably be drawn and what knowledge gaps remain? As with all studies, there are a number of limitations regarding the conclusions that can be appropriately drawn. But the authors were fairly frank in discussion of the data and the results, and overall, I think that this was a pretty well done study. For some reason, in all 4 of these trials, the individual doing the neurologic assessment of the patient was blinded to the treatment allocation, but the actual treating clinicians, and more importantly, the patient, were not. I'm not really clear on why they chose to do it this way. It seems like it would have been simple enough to include a little saline placebo in the endovascular treatment alone groups. Since all the patients underwent endovascular treatment, it's not like they would have needed to create like a sham procedure or anything that would have been similarly resource intensive. But similar to the prior trial we looked at regarding hypothermia, the clinician doing the neurologic assessment was blinded, as were the statisticians and the other trial personnel. One other unanswered question is whether the use of any other thrombolytic agents would have had an impact on the outcomes of this trial. All 4 of these papers used TPA, or alteplase, at a dosing range of 0.6 milligrams per kilogram in the SKIP trial and 0.9 milligrams per kilogram in the other 3. While it does seem unlikely, it is theoretically possible that the use of a different thrombolytic agent, such as TNcase or tenecteplase, or any of the other available agents could potentially have produced a different outcome. This meta-analysis included patients from China, Japan, and several European countries, specifically Belgium, the Netherlands, and France. As such, there is still a lack of data regarding Hispanic, Black, and Native American individuals. It is therefore unknown whether the data is fully generalizable to patients in these populations. All of the trials in this meta-analysis included patients that presented to a stroke thrombectomy center. This means that overall, across all of the trials included, the time from arrival to thrombectomy was impressively short, with the longest times being only a matter of minutes. But what about patients who require transfer or present to a small community or rural hospital? Patients that reside in rural areas often have long transport times and may have delays of potentially hours between presentation and actually getting the thrombectomy. Since we don't have good data to guide us yet for patients who may have a prolonged time of vascular therapy due to transfer, it is possible that our referral centers may continue to recommend thrombolysis for these patients, as this is still a fairly evidence-free zone. That being said, prior studies looking at patients with large vessel occlusions also demonstrate that unfortunately, thrombolysis is typically not very effective for these large and proximal occlusions, so it's still unclear what to do under these circumstances. This is a unique population that still needs to be studied. All of the trials included in this meta-analysis also had very short times between the initiation of thrombolysis and initiation of endovascular therapy. And this begs the question, did the TPA even have time to accomplish anything before the patient went to endovascular therapy? We all know time to work. When given a fibrinolytic agent, that agent has to have time to break down the fibrin that has been formed in order for clot dissolution to occur. But how quickly does that happen? If you consider the results of the prior stroke trials examining the effects of TPA on stroke patients, no effect was seen in the first 24 hours. In fact, no differences were seen between the groups until 90 days, suggesting that mere minutes probably isn't enough time for TPA to have any effect. Obviously, we aren't going to delay getting a patient to endovascular therapy, as the prior literature we have on the topic suggests that TPA works very poorly for large vessel occlusions. The argument for giving TPA in this population largely revolves around the idea that TPA may result in dissolution of any small remaining thrombi after removal of the large occlusive thrombus. However, as the data from this meta-analysis does not demonstrate an improvement, this suggests that there really is no benefit to giving TPA as long as endovascular therapy can happen in a fairly rapid timeframe. So what's the bottom line? Endovascular therapy alone appears to be non-inferior to endovascular therapy plus IV thrombolysis for patients with large vessel occlusion strokes. This appears to be true to within a 5% non-inferiority threshold. The caveat is, of course, this may not apply to patients that have long transport times. So unfortunately, this still leaves us having to make the best decision we can at the time under these circumstances. All right, you made it through, so I'm going to reward you with one more mental break before we wrap up. And that brings us to the end. Thank you so much for tuning in. I really appreciate you taking the time to do so, and I hope to hear from all of you soon. Please stay safe, stay healthy, and be well.